MONALEESA-3 was a trial that looked at a different CDK4/6 inhibitor, in this case ribociclib, in combination with fulvestrant versus fulvestrant and placebo. Here are my disclosures. So you all know breast cancer is the leading cause of cancer-related death in women. Ribociclib is a CDK4/6 inhibitor. It was approved for hormone receptor-positive, HER2-negative advanced breast cancer. The phase 3 MONALEESA-7 trial, which was conducted in premenopausal patients, was presented at ASCO and showed a survival advantage there with a hazard ratio of 0.71. And the phase 3 MONALEESA-3 trial is what won the approval based on progression-free survival data for hormone receptor-positive HER2 negative disease. And now we're looking to see what the survival data will look like. This is the design. Again, patients were randomized 2-to-1 to receive ribociclib plus fulvestrant versus placebo plus fulvestrant. What was somewhat unique in this study is there was a large percent, essentially half of the patients who were getting their therapy in the first line. In other words, they had not received any therapy for metastatic breast cancer. And they were being compared to those who were going to get fulvestrant in that same setting. So the combination was being compared there. So as the bottom, you can see the two groups, those are getting in the front line and those are getting it in the second line. Here are the survival data. And I think it is apparent from what we're looking at now that we again see, as George has talked about, a significant improvement in overall survival. The numbers are shown here. There are two landmark analyses at 36 months and at 42 months. What is interesting about the MONALEESA data is we have not yet reached the median in the experimental arm. So they are continuing on, and we don't know how far out that curve will go to tell you what the difference is going to be, but, and that's certainly good for the patients. But we have reached the median in the control arm, as you can see here. The landmark analysis tell you the differences at the 32-month or 36-month time point and a 42-month time point. They're shown here. There was a pre-specified boundary that if it crossed it would meet the survival analysis data. This is the second pre-specified protocol-defined survival analysis, and at the second one, the first one had not yet received. Had not yet achieved significance. At the second one, it clearly is. There will be a third one, and we'll see how far out that curve goes in terms of what's not been reached for the experimental arm so far. If you look by line of therapy, again, you see a significant difference. In the first line, we see the combination has not yet reached, again, the median, whereas in the early relapse or second line, you can see the difference between the two arms, the experimental arm versus the control arm. And again, both are significant with hazard ratios of 0.7. It's been remarkable to see the consistency across this. There has been an update that will be presented at the presentation itself on the progression-free survival. And a progression-free survival, again, is consistent with what was reported previously. We're now out to 33 months of progression-free survival in the combination arm for MONALEESA-3. So here are the forest plots. Essentially, all subgroups benefited. Those for which the median is crossing 1, making you question whether or not there's been a benefit, you can look at each of those groups, and they're extremely small numbers, 4, 7, 13. So the confidence intervals are very wide for those small numbers of patients, but for those where there are substantial numbers of patients in the group, you can see that across all subgroups there is benefit. The safety summary, after about 40 months of follow-up, there are no new safety signals. For this analysis, the key grade 3-4 adverse events are shown as follows. Neutropenia, of course, is the major adverse event, 57% versus 0.8%. This is mitigated with the 1 week off when the patients take a week off therapy and the counts are allowed to recover. Hepatobiliary toxicity is shown here, the difference of about 7 to 8%. and pulmonary disorders, which has become an important question based on what the regulatory agencies are asking us to look carefully at and caution about. In MONALEESA-3, there were no grade 3-4 pneumonitis or interstitial lung disease that were observed in either arm. In terms of QTc prolongation, you can see the differences here, 1.2% in the control arm versus 3.1% in the experiment arm, and there are no incidence of torsades or significant life-threatening dysrhythmias. In conclusion, ribociclib plus fulvestrant demonstrated a significant overall survival advantage. Patients who received it both in the first-line and second-line setting demonstrated a significant survival advantage. As you can see also in the overall population, the safety profile remains consistent with the longer exposure. There's no new signals. And the combined data set between MONALEESA-7 and MONALEESA-3 represents some 1,400 patients who have been treated with the CDK4/6 inhibitor ribociclib in combination with hormonal therapy. And it shows that, again, there is a significant but also clinically meaningful benefit in terms of prolongation of progression-free survival and now overall survival, regardless of whether the patient is premenopausal or postmenopausal, regardless of the patient received their drug in the frontline setting or subsequently.
As you can imagine, it's a pleasure to comment on these two trials, and I can only congratulate you for getting up early and having seen that data. It's great data. The two authors said that they're biased, but I think I can also say that I'm not involved in either trial, that they're really clinically highly meaningful data for our patients. You saw by Dr. Sledge the 50 months to chemotherapy. This is a game changer in metastatic breast cancer. But let's take one trial after the other. The MONARCH-2 trial shows for the first time a significant overall survival advantage in a purely second-line cohort of pre-postmenopausal patients. It's the first time we see overall survival data for abemaciclib, which is one of the three CDK4/6 inhibitors, and the delta of 10 months is really clinically meaningful, but also the 46 months patients live with their metastatic disease in the second line with the abemaciclib. MONALEESA-3, as Dr. Slamon pointed out, sort of rounds the data for ribociclib. It's a postmenopausal study, but they presented earlier another trial at ASCO this year for the premenopausal patients. And MONALEESA-3 for the first time gives us now data in the first and second line setting, so patients who have not been receiving any endocrine therapy before that, and that makes it also highly clinically meaningful because we were always struggling with whether to give these drugs first or second line, and I think now we can see there's a first line survival benefit. I think that should be the new standard of care, CDK4/6 in the first line setting. So the data are highly clinically meaningful. I think they're going to make a huge impact in how we treat metastatic breast cancer. It's a disease where the epidemiological registries give you a median of 2.5 years median survival. And now you saw in the MONARCH-2 study, which is a slightly later line of therapy, 46 months median survival. That means half of the patients even live longer. And with the MONALEESA-3 data, we didn't even see the median because the patients are doing so well, but the control arm was at 46 months. So you can see that that is stretching out quite a bit. So I think the data will make sure that these drugs are going to be standard. They're going to be, should be, in my opinion, first-line standard in the metastatic setting, because you can never guarantee that a patient comes back for a second line of therapy. They may be too sick. They may not want to come back. So we should give the best drugs first. And the overall survival differences are also meaningful for access to these drugs, because some of the health technology assessments in individual countries around Europe do require overall survival for reimbursement. So this data is going to change that. And lastly, and I will stop there, if Dr. Slamon was one of the pioneers of the HER2 story, and he cannot say that, but I think that these drugs will be a similar success as the HER2 story for our patients with hormone receptor positive breast cancer. And these drugs will need to be explored, and they already are doing that in the early breast cancer setting, because there we cannot just prolong survival but reach cure. And these trials will hopefully reach out, be presented in the next year or two, and hopefully also at the ESMO meeting. Thank you very much.